The next session of this really kind of transitioned us into really talking about getting into some of the real applications on the challenges and opportunities, as it's called, for multi-level intervention research. In particular, we're going to be looking at practical ways of trying to figure out how do we select interventions, what are some of the conceptual and theoretical issues about timing and other things, and thinking about appropriate interventions, and then talk about some of the research methods that are very appropriate for thinking about getting into this field in a way to really address some of the extraordinarily challenging conceptual questions we talked about this morning. So my first speaker is going to be Brian Weiner. He's professor of the Department of Health Policy and Management at the School of Public Health at the University of North Carolina at Chapel Hill. Dr. Weiner is a good friend, and he's also director of the Program of Healthcare Organization at the Cecil Shepps Center for Health Services Research. His research focuses on such things as adoption, implementation, and sustainability of innovations, very appropriate for this meeting, in healthcare organizations. And he earned his PhD in organizational psychology from the University of Michigan.
So I would like to begin with a Sufi teaching story that goes something like this. You think that because you understand one, that you also understand two, because one and one make two. But you forget that you must also understand and. And I think that actually does a nice job setting up this particular talk and the paper that we wrote about the search for synergy. And in the interest of disclosure, we are going to shift in this particular 10 minutes to a different model of thinking about multi-level interventions from the biopsychosocial model that Steve Taplin represented to the social ecological model, which was one of the three that he mentioned. So if you feel confused, that's probably because this is a good example of where different people using the word multi-level have different ideas about what that means. So I just want to alert you to that. The social ecological perspective provides a very compelling justification for multi-level intervention. While there are numerous variants of the social ecological perspective, they share two basic principles. The first is that human health results from the complex interaction of personal factors and multiple aspects of social and physical environments. The second principle is that these multiple factors that influence health are interdependent. That is, they mutually influence each other. On the basis of these two principles, proponents of the social ecological perspective contend that multi-level interventions should be more effective than single-level interventions. The key to designing an effective multi-level intervention, however, they note, is to select and combine interventions that work in complementary or synergistic ways. All good advice. Conspicuously absent, however, are discussions of how, when, or why interventions at different levels of influence work together in mutually reinforcing ways. The problem is that without such guidance, multi-level intervention designers run the risk of combining interventions that produce scattered, redundant, or even potentially contradictory effects. So using a causal modeling framework, we describe in the paper, and I'll briefly touch on it during this 10-minute presentation, 5 strategies for increasing the potential complementarity or synergy among interventions that operate at different levels of influence. Given the importance of interdependence in the social ecological framework, we focus on 2 types of causal relationships, mediation and moderation. To illustrate the potential strategies for increasing synergy or complementarity, we in the paper, and as you'll see in the slides that follow, focused on multi-level interventions designed to improve the quality of treatment for locally advanced rectal cancer. In the accumulation strategy, interventions at different levels produce a cumulative impact on a common mediating process or pathway. Note here that the effect of each intervention in this particular strategy is not conditional on the other interventions. Rather, the interventions exhibit what scholars in organization science call pooled interdependence, meaning that each intervention makes a discrete contribution to the outcome, through the mediating variable or pathway without being dependent upon each other. In the amplification strategy, by contrast, the effect of one or more interventions is conditional on another intervention. One intervention increases the target's audience's sensitivity to or receptivity to the other interventions. That is, one intervention amplifies the effect of other interventions on the mediating process or pathway. And so you can see in this example, the use of reimbursement is used to increase the sensitivity to or receptivity to changes in public reporting or interventions that are designed for public reporting or in opinion leader interventions trying to change social norms around the provision of chemoradiation therapy for patients with locally advanced rectal cancer. For those of you who are curious, this particular strategy exemplifies a form of mediated moderation. In the facilitation strategy, the effect of one or more interventions is again conditional on another intervention. However, instead of boosting the signal, the conditional intervention, in this case the clinical reminder, clears the mediating pathway for the other interventions to produce the desired outcome. In other words, one intervention removes the barriers or facilitates the effect of the other interventions. This strategy is another form of mediated moderation. In the Cascade Strategy, an intervention at one level affects the desired outcome in and through one or more interventions at other levels of influence. The interventions demonstrate what scholars refer to as sequential interdependence, meaning that the outputs of an intervention at one level become the inputs of an intervention at another level. By linking multiple mediating processes into an integrated causal pathway, cascading interventions create a circuit through which the effects of interventions combine and flow. And I must say I had a little bit of, whoops, wrong slide, a little bit of concern about calling this the Cascade Strategy because it implies a trickle-down effect. But in fact, it's quite possible for the effect to trickle up. Many who have worked, for example, in the community care network study or in community empowerment studies or in community-based research know that sometimes in order for interventions at lower levels of influence or at smaller units of human organization to be effective, change has to occur at a higher level of influence or a higher level of higher unit of analysis. And then finally, in the convergence strategy, interventions at different levels mutually reinforce one another by altering the patterns of interaction among two or more target audiences. The interventions in this particular strategy exhibit what scholars call reciprocal interdependence, meaning that the outputs of some interventions become the inputs of other interventions and vice versa. So that's the difference between the sequential and the reciprocal forms of interdependence. They're not necessarily linked in a chain, but rather there's this constant back and forth. I know that's just a gloss of what we talk about in the paper, and I certainly hope that you will be intrigued enough to read it. I think what we have tried to do in this paper is to develop a general framework to guide people's thinking about the causal logic for multi-level interventions. And this can be useful not only for intervention designers, but also for reviewers of multi-level intervention proposals. I think what we wish to do is to avoid a kitchen sink approach, which can be very wasteful and expensive and perhaps burn through a lot of goodwill among stakeholders in communities, healthcare delivery systems, and patients and families. Theory and research clearly play a critical role in clarifying the causal logic for combining interventions at multiple levels, and this raises several questions for discussion. The first is, do we have theories that explain how determinants at multiple levels of influence produce health or other outcomes? I might be over-exaggerating, but it seems to me that we have psychological theories that look at intrapersonal factors. We have organizational theories that look at organizational factors, and we have political theories that look at political factors. But they don't necessarily look at how factors at multiple levels of influence interact in order to produce health and other outcomes. The second question is, do we have enough cross-level research that examines the interdependence of variables or determinants at multiple levels of influence? What I think we need more of is sort of cross-level research. So if we're going to stick with the ANOVA framework and think about multi-level modeling, we need to not only focus on which level explains the most variance or which factors at any given level explain the variance at that level, but we really do need to be looking at cross-level effects in order to understand the interaction of causal factors at different levels of influence. And then finally, do we have a sufficient grasp of the causal mechanisms through which many commonly employed interventions produce their effects? And I've been struck by several papers that have been published in Implementation Science and other journals that have looked at the intervention of audit and feedback, which, as many of you know, has been studied in hundreds of, or at least tens, if not hundreds of times in various places. But it's only really in the last 2 or 3 years that we have begun to ask the question, how or why does audit and feedback work? In other words, what is the theory about the causal mechanism through which this works? And some very interesting work is now occurring. It's just surprising to me that we had to do 40 or 50 studies before somebody finally wrote a paper about that. So those are the 3 discussion questions I would like to encourage the individuals at the tables to take up when we have our discussion time. Thank you.
Thank you, Brian.